Welcome to this explainer. Look, if you're handling billing for digital health, you already know the ground feels like it's constantly shifting under your feet. And honestly, the risk of payer recoupments is enough to keep anyone up at night. So today, we're going to clear up the immense frustrations surrounding remote monitoring codes. We're breaking down the exact guardrails for remote patient monitoring and remote therapeutic monitoring so you can stay completely compliant and audit-proof.
Here is our agenda. We'll be looking at RPM versus RTM basics, RPM code selection, RTM code selection, the crucial 16-day transmission rule, and finally, audit red flags. Let's jump right into Section 1, RPM versus RTM basics.
Now, they sound super similar, right? But RPM and RTM are actually fundamentally different beasts. RPM, or remote patient monitoring, is entirely about the automatic digital transmission of physiological data. We're talking hard, objective numbers, like blood pressure, ECGs, or body weight, and they have to be gathered by an FDA-defined medical device. You can't just have a patient verbally tell you their blood pressure. It literally has to digitally transmit. On the flip side, we have RTM, or remote therapeutic monitoring. This tracks things like respiratory status, therapy adherence, or pain levels. Unlike RPM, RTM actually allows for self-reported patient outcome data right alongside the device-gathered information.
Moving right along to Section 2, RPM code selection.
Okay, this table right here is basically your mental cheat sheet for RPM billing. It shows how the billing sequentially builds across an episode of care. It kicks off with code 99453 for the initial setup and patient education. You just report this one once per episode of care. Next up is 99454, which covers the actual supply of the device that handles those daily recordings. And you bill this every 30 days. Then we get to the human element. Code 99457 covers the first 20 minutes your clinical staff or physician spends managing that patient's care based on the data, per calendar month. And hey, if they spend 40 minutes, you just use the add-on code 99458 for that additional 20-minute block. But here's the catch. Looking directly at the CPT rulebook language for that management code 99457, there is a strict mechanical requirement. It mandates at least one real-time, interactive communication with the patient or caregiver during that calendar month. Just looking at a dashboard of data for 20 minutes, yeah, that's not going to cut it. You have to get the patient or caregiver on a live communication to discuss the treatment plan. If you miss that interactive piece, you cannot report 99457.
Let's flip over to the therapeutic side with Section 3, RTM code selection.
You'll notice a really parallel structure here to what we just saw with RPM. Same logical flow, just a different code family. 98975 covers the initial setup and education for RTM. For the device supply, it gets a bit more specific based on the body system. You'll use 98976 for respiratory system monitoring and 98977 for musculoskeletal monitoring, each billed every 30 days. For the management side, code 98980 covers that first 20 minutes per calendar month, and 98981 is your add-on for each extra 20 minutes. And yes, absolutely, just like RPM, that base management code 98980 requires that live interactive communication. Now for a cornerstone of your compliance. Section 4, the 16-day transmission rule.
I need you to engrave this number into your memory, 16. To report the device supply codes, that's 99454 for RPM or 98976 and 98977 for RTM, you are strictly required to have a minimum of 16 days of data transmission within a 30-day period. So if your hypertensive patient only transmits blood pressure readings for 14 days in a 30-day window, you cannot bill the device supply code for that month. It is a hard stop. Less than 16 days means no billing.
When calculating the cumulative monthly time for those 20-minute management codes, auditors want to see your staff meticulously tracking 3 specific things. You're counting the time spent actively analyzing the transmitted data, time spent adjusting the treatment plan based on what that data says, and time spent actually conducting those mandatory interactive calls. It's a cumulative total for the month, but your documentation needs to clearly show these specific steps to justify that 20-minute threshold. And here is an absolute golden rule for compliance. No double dipping. The time you spend on RPM or RTM management must be completely separate. It can never be double counted toward chronic care management or CCM, and it can't be combined with the time used for other office EM visits on the same day. If a provider spends 30 minutes with a patient and 15 of those are an EM visit and 15 are discussing RPM data, you have to strictly partition that time right there in your documentation. Finally, let's look at Section 5, Audit Red Flags. Pay very close attention here, because these are the pitfalls that literally cost practices money. Auditors are actively hunting for claims that build device supply codes with fewer than 16 days of recorded data. Another massive target, billing management codes without clear documentation of a live interactive communication. Also, you absolutely cannot try to co-bill RPM and RTM for the same system or data during the exact same period. It's one on the other. And lastly, for RPM specifically, using some generic, non-FDA-defined wellness tracker will trigger an immediate failure if you're audited. So, let me ask you, are your remote monitoring claims completely audit-proof? Review your documentation practices today. If an auditor walked into your practice tomorrow, would your 16-day transmission logs and interactive communication notes actually hold up to scrutiny? The rules are rigid, for sure, but by respecting these boundaries, you can confidently integrate these amazing services into your practice without the anxiety. Don't forget to like, share, and subscribe to Decode Healthcare with Harshaw.